So Shub, since you're representing for us the sort of realist that's out here for all of our excitement, enthusiasm, let me ask you a little bit, as shifting gears a bit, let's cure some pancreas cancer. What's the role of surgery today in pancreas cancer? How's that shifting in your way of thinking?
So I love my surgeons, work very closely with them.
Well, they have knives.
You've got to be nice to them. You're right. But I'll tell you, and I'm not saying it just because of MD Anderson, our surgeons are exceedingly thoughtful in selecting patients. So I think patient selection is a big thing in surgery. Yeah. So you really have to select the patients.
Well, let me go the other way, because we're talking to mostly oncologists. Is surgeon selection important?
Yes, I think so. I mean, there's data saying, Whipple surgery is a big surgery. I think it really takes a lot from the patients. It needs a lot from the patients' families. There has to be a lot of education around exactly what you're getting into and how you can recuperate, because it's, patients sometimes, it's not a modified radical mastectomy. It's a big, not that I'm saying that's small surgery, but that is what I'm, but
it's complicated.
It's complicated. You really mess with the gut. And it really can cause a lot of complications, and patients can take a long time to recover. So
Paul, I guess most of us probably use multidisciplinary clinics or multidisciplinary meetings to review this. How do you guys handle a new pancreas cancer in your shop?
So we believe very strongly in multidisciplinary clinic. I think almost every patient should be discussed for discussions of genetic testing, surgery, palliative care, supportive care, obviously medical oncology. I think we've pushed the boundaries of who can go to surgery on one side. We've thought of more people as potentially surgical, but we've also limited the people who we really think are going to be cured just by surgery alone to almost no one. I think, we're convinced that you need to have more than just surgery. But the quality of the surgeon and I'd say the willingness of the surgeon to understand the whole treatment trajectory, what's chemo, what radiation is going to come, is really critical.
Yeah, Ed, what's your take?
Yeah, I think that we've seen a clear shift in the landscape, creeping further and further more with more chemotherapy first. Yeah. The advent of even having a borderline resectable category is recognizing that patients that we considered resectable before, surgeons that would sell the patient on being able to, this is your chance for cure, recognizing that if there's a good enough prediction based on imaging that you will have a high likelihood of a non-successful surgery, that really we should be trying to treat these patients more and more upfront with chemotherapy. And we're seeing that shift even further to even discussion about in resectable disease.
Yeah, I mean, I think the fight we're having in our shop and continue to have is, let's say it's that 1 centimeter you tripped over at pancreas cancer, and obviously resectable right from the get-go. And let's even make it more complicated. The OR is booked for 48 hours from now, and then they presented a tumor board just to make sure that's okay. Patient's ready to go. Allison, do you derail that and you say, no, we want to give you some chemo, or that patient's going to surgery? I made it hard on purpose.
You did. So that it's hard to derail it when it's coming from a multidisciplinary tumor board and the surgeons are there and they have the tumor up on the screen and no vessel involvement. It's beautiful, separate, everything, and take it out.
Yeah. And I sort of think if it was me, I'm like, take it out. I
think most patients.
I think for those smaller tumors, yes,
But what I was saying is actually happening all over the place. Is that you find a completely resectable tumor, and we're saying that this, and I'm fighting the same discussion. I don't know what they're at, to doing this neoadjuvantly for other reasons.
So pancreatic cancer in the majority of cases, even if it's resectable, is a systemic disease. So there is some micrometastatic spread somewhere. And I think we are, and our surgeons are actually very cognizant of that. So in MD Anderson for the last decade, or for longer than that, neoadjuvant therapy has been the standard of care for these patients coming through.
But our best data,
even small tumors, neoadjuvant therapy, because I think when you really have to select patients, and we see that many times patients get resected, they come in to see us in 2 months and they've got metastatic disease. Now that is a big surgery to do for a patient, put them through a lot for something which is metastatic. So the two things which happen when you do the resectable, when you give them neoadjuvant therapy, whether it's chemotherapy or chemoradiation, is that first you select those patients who are actually going to do really well, that really are going to benefit from the surgery. And so you know the biology of the disease that you're getting into, and I think that's very important. We also have something called a prehab program in which the patients get, instead of rehab, they get prehab. That means they get ready for surgery, they get exercise tips. So
But
you're
not
ready.
everybody's MD Anderson, so this is
understand
not the, this is not real here.
But they don't need to do prehab, but I think they really need to, I think everybody needs to take a deep breath and a step back and seeing what is the ultimate goal. Is the ultimate goal just resecting it, or is the ultimate goal really curing the patient in a meaningful way?
My sort of pushback on this is that the data we quote is classic adjuvant data, right? Surgery first, now FOLFIRINOX afterwards. It's not neoadjuvant. And those are the best curves that anybody's been able to produce. And so we're hoping that by messing with this in some way, we'll make those curves better, right? And what we've got now are single center series.
But so in ASCO GI, the Japanese data was presented, which was a phase 3, phase 2 going to a phase 3 randomized trial in which patients got gemcitabine with S1. We don't use S1, but gemcitabine S1 for resectable disease, or they had and surgery, or they had resection followed by S1, and they had a clear survival benefit for the patients who had neoadjuvant therapy. So I do think in resectable disease, neoadjuvant therapy should be the standard of care for pancreatic cancer, whether it's in a bigger center or in a smaller center. I think every patient, because a majority of the patients do have systemic disease, there has to be recognition of that fact. And
So
whatever you use for neoadjuvant is different, but I think it should be.
We now know, and I think we'll discuss this, that the best thing you could do for a patient after surgery is give FOLFIRINOX. And the reality is that it's a lot harder to give FOLFIRINOX after surgery than before surgery. And so we try to convince patients at least getting some of that 6 months up front will be easier for them. And that's the truth. I think there's no question they'll tolerate it better before surgery. So we often split it up just for that toxicity issue, I think. There's no question they're going to need it and after surgery if they can handle it.
And I think probably we all work with surgeons who have gotten fancier and fancier. They're doing lap assisted and all sorts of techniques like that. Do you all feel that that's appropriate, or should we be, you're shaking your head, what do you think?
Don't quote me, but there was a recent...
You're going to be quoted. This is the ultimate
What I'm saying,
quote.
don't quote me because I'm going to get the author wrong and the abstract wrong.
I see.
But there was recent data that if you are going to have pancreatic cancer surgery, you should not have robotic surgery. The outcomes were
It was
inferior.
FDA data, I think. There was a warning.
Yeah.
Review
So,
back,
so you can quote me on that.
So
we don't do that unless it's part of a trial.
Yeah.
So we have one of our surgeons who is doing kind of robotic surgery as part of the trial and everything. So that is developing, but I think that's far away from the prime time of doing that. So I think, kind of open surgery is, I'm not a surgeon, but open surgery is kind of the way to go, at least in pancreatic cancer. But I do think very strongly that neoadjuvant therapy should be given to 90+% of patients with resectable disease, if not near all of them.
I mean, I think there's a lot to be desired, and I think what I've experienced is that there's a definite shift of less resistance from the surgical side about this approach of using neoadjuvant therapy. There's the advantage of being able to test the biology and see what your response is going to be, and I think that's the advantage also, in addition to tolerance, pre-Whipple or post-Whipple, is also being able to see what happens to the tumor, which you can't in adjuvant setting. And so I definitely think, and there's trials that are ongoing that are going to start giving us hopefully data that will be in line with what you're saying, because right now, I agree with your perspective. I don't know that we have the data to be able to convincingly state that the standard of care right now is to do neoadjuvant therapy in all resectable cases.
I agree. I don't think the data is there. We all think it's going to come there. And there are studies ongoing that may provide more information, but there isn't even a randomized pre or post study of FOLFIRINOX.